Welcome all of you to this live program at Orthopedic Principles. Today, our guest of honor is Dr. Osama Kashlan from New York. Dr. Kashlan is the Director of Spine Surgery at the New York Presbyterian Brooklyn Methodist Hospital and the Associate Professor of Clinical and Neurosurgery at Weill, Cornell Medicine. He received his medical degree from the Emory University and completed his neurosurgery residency at the University of Michigan. He then completed a complex and minimally invasive spine surgery fellowship at the Emory University, followed by a fellowship in endoscopic spine surgery at the University of Washington. He's a member of the Endoscopic Spine Surgery Research Group and has been the inaugural secretary of the International Spine Endoscopy Research Foundation. So today is my great honor to introduce you Dr. Osama and Kashlan from New York City. Over to you, Dr. Kashlan.
Yeah, thank you so much, Professor Hitesh, and I appreciate the opportunity. It's an honor to be here today with you all to talk about something that's very dear to me, which is spine endoscopy, and specifically today talking about endoscopic lumbar microdiscectomy, so a very specific indication for endoscopic spine surgery. I wanted to first talk about my conflicts of interest. So I'm on the teaching faculty at Arthrex and at Joymax, so that will obviously affect my talk because I'm all about endoscopy. So first, before talking specifically about endoscopy, I wanted to talk about what makes spine surgery minimally invasive. What is a minimally invasive procedure? And I remember listening to one of my professors saying, an ACDF is the initial minimally invasive surgery. And at that time, I didn't understand what he meant, but really, in a way, an ACDF or any type of anterior cervical approach is a minimally invasive surgery because it respects tissue planes. You're not going through anything. Any big muscles or anything like that. You minimize the collateral damage when it's done in a very delicate way, lowers postoperative pain, shortens recovery and length of stay, and decreases complications with less need for future interventions. And that's what minimally invasive surgery is. So we have numerous approaches to the spine, and really what makes something minimally invasive are these, six, categories that we have here. Obviously for discectomy, our approaches are going to be posterior or posterolateral, but for fusions, obviously, what makes something minimally invasive is a little bit different. So for a minimally invasive approach for a disc, which we know is a posterior approach, what makes something minimally invasive? It's again going through natural tissue planes if possible, rather than through muscle, so muscle sparing if possible. But in posterior and posterolateral approaches, you are really either splitting the muscle or you're detaching the muscle. And minimally invasive options really are important and or the reason why they work well in terms of decreasing the morbidity of the patient is that you are spreading the muscle rather than detaching it. And what can make things even less invasive are decreasing the number of channels possible and using the smallest working channel diameter. Because if you think about it, anytime a radius is increased by a certain number, we know that the area is pi r squared. So you're really, you're double or not doubling, but you're going by a power of what increase in the radius is. So based on that, endoscopy, and especially uniportal endoscopy, makes sense for it to be the most minimally invasive approach to treat a lumbar disc because some of these endoscopes are just 6 millimeters in diameter, and companies are working on getting it even smaller. And when you do uniportal endoscopy rather than biportal, then you really have just one working channel. So you have one working channel, as of now, 6, 7 millimeters in terms of width. Eventually, I have no doubt that it's going to be even maybe half that the diameter, which will make things way less invasive than we even have them done now. So it's important to do that, and that's why, again, in my opinion, uniportal endoscopy for discs are the least invasive options that we have for our patients currently. But it's also very important to have either the same or better outcomes when compared to traditional methods. If you're delivering care in a minimally invasive approach, but you have more disc reherniations or you have more nerve injuries or more incomplete decompressions, then that's not really doing our patients well. And maybe in your hands, it's better for you to do the more traditional method. But ideally, you are able to do these operations with very good long-term outcomes improving the short-term outcomes because it's a lot less pain when you're using smaller instruments and smaller diameter channels and a decreased number of working channels. But again, to give us the same long-term outcomes and better short-term outcomes, which in my opinion is what endoscopy adds to the armamentarium of a spine surgeon. So as you can see here, this is a Joymax system, but many systems have the same thing. You have transforaminal scopes, which we'll talk more about that later, which are the one here on the left of my screen. And then you have the interlaminar scopes, which are on the right side of my screen with different diameters, as you can see here. But you can see for the transforaminal scopes, it's 6.3. This is the Joymax system. And then a 7.3 for the small interlaminar system. But again, over the next couple of years, I have no doubt that these diameters will get even smaller and our operations for our patients will become even less invasive than they are now. So that's kind of talking about minimally invasive spine surgery in a nutshell, what our goals are from delivering minimally invasive care to spine. And then now specifically talking about lumbar disc herniations, why do I think endoscopy is better than what we are doing now, which is tubular decompressions or open decompressions, which again, great options, great long-term outcomes, but I think we're able to deliver the same level of care in terms of outcomes with decreased morbidity for the patients with endoscopy. And the reason why is first, I think the utilization of the transforaminal route. We'll talk more about that in a second. Most of our discectomy options that we do with a tube and with open procedures are dorsal approach, either muscle detaching or muscle splitting. But with an endoscope, because of the small diameter, you're able to come in from a very posterolateral approach through the foramen to get into the canal to take care of central or paracentral disc herniations with decreased nerve retraction, decreased soft tissue manipulation, decreased dissection, and bony removal. And theoretically, that should decrease morbidity to the patient. So really, endoscopy helps us with doing all those things via the transforaminal approach. But another thing that's very important to note about endoscopy is, irrigation is the best barrier to durotomies. It acts like a retractor. So when you have irrigation in there, because all endoscopy, for people that have seen it, it has a constant flow of irrigation fluid, which is usually normal saline, and it's like a nice gentle retractor over the whole dura, rather than putting in a retractor and really having an acute focal curve and retracting nerve roots. The irrigation is a nice barrier to durotomies because it just kind of retracts everything out of your way. And because, if you think about an endoscope as your eyes are at the level of the lesion, rather than a microscope where your eyes are far away from the lesion, in endoscopy, I don't really care if my patient has a BMI of 15 or a BMI of 60, because it's the same operation. Once you get to your target region and your target lesion, it doesn't matter how large the patient is. It doesn't matter how small the patient is. You're not dealing with, for bigger patients, you're not dealing with, hubbing your instruments and having difficulty with reaching your lesion. And for very, very small patients, cachectic patients, you're not worried about infections because the infection risk is almost zero in endoscopy. And this has been proven over a huge a huge study over multiple institutions around the world. So like we talked about, uniportal endoscopy gives us the ability to utilize a transforaminal approach. As you can see here, the typical approach to discectomy is an interlaminar approach. That's what we're doing with the tubes. That's what we're doing with an open approach. But with an endoscope, you're also able to get to the same lesion through the foramen with minimizing the bony removal, minimizing the collateral damage as you get there. So, really the transforaminal approach is a game changer and is only able to be done with an endoscope. So I first wanted to talk about central and paracentral disc herniations. And again, the talk today is really very, very brief. I wanted to stay within our time period, but I wanted to just have a glimpse of what pathologies could be treated with endoscopy, and also just to kind of get people starting to think about how does endoscopy make sense for me in my practice. So I'm splitting up the disc herniations as central, paracentral, so intercanalicular, and then foraminal, extraforaminal, because those are, in my opinion, two separate pathologies. So when do we use the transforaminal approach and when do we use the interlaminar approach? And again, there's so many nuances to this, and it was very difficult to kind of put it into categories, but I think this is the way that I think about it for most cases. Is, you know, the interlaminar approach is great for L5S1. Why is that? Because the iliac crest is usually in your way, and a transforaminal approach to L5S1, even though doable, is difficult at times and puts the dorsal root ganglion, puts the DRG of L5 at increased risk. So I think an interlaminar approach is probably more straightforward and makes more sense at L5S1 for most cases. And then at L1 to L5, when there's concomitant ligamentum flavum hypertrophy. So the beautiful thing about endoscopy, I think of it more of having a sniper. You're a sniper rather than having a machine gun. The way that you look at MRIs when you're doing endoscopy is very different than when you're not doing it. You look at specifics of what is causing the stenosis, what is causing the compression. Specifically, is it bony? Is it disc? What's the width of my canal? Like these are what's the diameter of the foramen? Those are things that when we're doing tubular or open surgery, we don't really pay attention to because you're going in there anyway and you're taking care of whatever needs to be taken care of. But with an endoscope, it's very important to know those things. So if someone has, let's say, nerve compression of L5 at L4-5 because of a disc herniation and has hypertrophic ligament, in my opinion, you get a much nicer decompression going interlaminar because you're able to detach the ligamentum flavum, take it off completely, and then also go in further and grab the disc herniation in a way that a transforaminal approach, even though doable, you know, once you start doing a lot of endoscopy, you realize that I could really do a dorsal decompression of the lateral recess and a ventral decompression of the lateral recess with a transforaminal approach. But at least in my hands, I'd rather go interlaminar in that situation because it's just more straightforward, in my opinion. So that's when the interlaminar approach to a lumbar disc and a central paracentral disc is better, in my opinion. For transforaminal, really L1 to L5, if you have a disc with not much ligamentous hypertrophy, game changer, and really, in my opinion, is something that elevates the standard of care for treatment of lumbar discs. So I wanted to go through a few examples. So this is an example of a patient who came in with a severe left-sided S1 radiculopathy from a large disc herniation, exhausted all non-surgical measures, and was a candidate for surgery. This over here is just a quick preview of what you do for the docking for you know, for an interlaminar disc. You really, the thing that's very notable here is, you know, when we're doing this with a tube or you're doing this open, I guess more with a tube, you're always taught, at least I was taught, to be in line or parallel with the disc space. But with endoscopy, our goal is to maximize the interlaminar window. So if you could see here on the AP, you know, we really are kind of parallel with where the spine. So if the spinous processes are like that, our access is kind of splitting the spinous processes to maximize the opening to the interlaminar space or the interlaminar window. And that way, you know, there are a lot of cases for a big window like this. You don't take any bone down to get to the disc, which is, I think, a good thing, and it decreases morbidity, decreases the surgical time. But you see, when you're looking at the lateral here, our access is kind of coming up from the bottom and aiming more cranially in a way that's very parallel to the spinous processes there. So it really minimizes the amount of bony removal, minimizes the morbidity, even when you compare this to a tubular disc or tubular decompression. So I have some videos here that are from Arthrex. So once you get down there, what are you seeing? You get down there, you kind of clean up the soft tissue. You clean up the soft tissue on the bottom part of the bone, and then you get this cutting instrument and you're cutting through the ligamentum flavum. And the nice thing about this, you know, it seems like it's dangerous, but when you cut and a little opening gets in there to the epidural space, you have the water, the greatest retractor ever. Or not the air water, the normal saline goes in and just pushes the dura away. So the second you get an opening, you have your irrigation pressure pushing the dura away. So this is actually a very safe move, even though if you're doing this with a tube or you're doing this open, you think, oh man, this is like super scary. I'm getting this sharp instrument near the dura. But if you're careful, and you're go through it in a very meticulous way, then it's something that's very safe. And again, the irrigation goes in and pushes everything away, and then you're able to kind of detach the ligament there. So after you go in there, you want to kind of get some of the ligament out, push your working channel in, and then you're trying to find the edge. You're trying to find the edge of the dura and mobilize it, because the next step here is after you kind of mobilize it, you go through all these adhesions that are laterally there, is you're going to want to push the working channel in and retract the nerve root with the working channel, which is what's shown in this slide right here. So you're using your working channel to retract the nerve root out of the way, and then boom, your disc herniation is right there. And then you do your discectomy in a way that's very, very protected from the nerve. And honestly, for someone with a big interlaminar window, you can get to this step within maybe 15 minutes or so. So it's a very fast procedure once you get used to it. But again, the learning curve is long, obviously. So you get down there, you're able to get all your instruments in there, do a great discectomy, and send your patients home. What does this look like when you're actually operating? So this is a video of what one of my chief residents do in an endoscopic case, a uniportal endoscopic case. So you see you have your hand there holding a working channel, also holding the scope, and then your right hand, if you're right-handed, is using the instrument. The instrument goes through the scope, and you have screens all around the room. So you can see it's very ergonomic, and this is how the interlaminar approach looks like there. So that's interlaminar. Now let's go to transforaminal. So for transforaminal, when is a good case for that? This is an example of a little bit more advanced case. It's someone who had a open discectomy performed years before she presented with a reherniation. In a situation like this, you could go back in and do an open laminectomy or tubular laminectomy and kind of go through the scar tissue to get to the disc herniation. Very reasonable to offer this patient a fusion as well. But with endoscopy, you're able to go through the transforaminal approach in an area where there's really not much scar. So if you do a transforaminal approach, you go through this area here, which was untouched by scar, and you're able to get this disc and at least give this patient another chance before requiring any type of fusion if she reherniated again. So this patient presented with a left-sided radiculopathy. This is a patient who has a disc herniation, not much ligamentous hypertrophy, probably because it was removed in the last operation. So this is a patient that I think is great for a transforaminal microdiscectomy. So there are many nuances to the approach to the transforaminal window. There's different remixes, I'd say, of the transforaminal approach, trans-SAP, where you dock on the superior articulating process versus docking directly into the foramen. So there's many different nuances of this that I think would need a whole lecture to itself. But pretty much you're aiming to go through the foramen, and the workhorse approach is this, what you see here on the left on the AP, where you're hugging the ipsilateral pedicle, the top of it, and then you're kind of aiming to the mid towards bottom of the pedicle contralaterally. So that's kind of our approach angle on the AP. The picture on the right is after you do all your reaming or drilling or whatever you end up doing to do your transforaminal approach. That's kind of an example of, this is our probe showing us how medial you can get into the canal to check and make sure that you got all your disc out. But actually for a transforaminal approach, depending on how lateral you start versus how medial you start, you could really get a disc there's been times that I've went all the way over to the other side, ventral to the dura. So you really are able to do a huge, do a discectomy on a large central disc. You're able to do it. Really, any decompression procedure could be done with the endoscope. So this is a post-op scan showing that the lateral recess is much more free, not perfect, but good enough, and she felt better. And this is an example of the disc fragment that we were able to get out through through a 6 millimeter incision. So this is a video here, but actually this is a thoracic disc. So this is what after you get really good at doing lumbar microdiscectomies with a transforaminal approach, then you want to do thoracic discs, which I think, in my opinion, will become the new standard of care for treating thoracic discs, doing this with an endoscope. I just didn't have a great video of a transforaminal approach. So this was a better video, so I wanted to kind of show that to you. So this is, after you did your drilling, your reaming of the foramen, that's the disc there that is ventral to the cord. And then you kind of just get it out. This is obviously, I think it's like 4x or 2x in terms of the speed. And then you check at the end, you get the disc out there, and then you're decompressed. But you see the visualization is perfect. This patient is actually a larger patient, so doing this case through an open approach or doing a thoracotomy or whatever, it would have been difficult. And here you see completely decompressed ventral aspect of the cord. Again, through a 6 mm incision. And this is very similar to how you do a transforaminal lumbar microdiscectomy too. It was just a better video, which is why I utilized it here. So that's it for paracentral central disc herniation. So kind of the gist of everything is if you have L5-S1, you do interlaminar. L1 to L5, it depends on if there's ligamentous hypertrophy as well or not. If there's ligamentous hypertrophy, you honestly could go both ways, but I go interlaminar. If you don't have ligamentous hypertrophy, it's just a disc, then transforaminal is the way to go. So now let's talk about foraminal, extraforaminal discs, because this is a separate pathology. For these, in my opinion, transforaminal is usually what you do. What is another approach that you could do? You could do interlaminar contralateral. So if you have a disc herniation, let's say at 5-1, foraminal disc or extraforaminal disc on, let's say, the left side, you could come in interlaminar on the right side, and then using the water pressure or the irrigation pressure, it pushes the dura down, and it really gives you a beautiful access to the contralateral foramen. And you could do that when the iliac crest is high. If the iliac crest is very high, then you could do an interlaminar contralateral approach to take care of that disc herniation. But most of the time, people use a transforaminal or a remix of transforaminal called a transpars approach. The transpars approach is very similar to our paracentral approaches that we use with a tube. It's just a more medial approach or starting point to get you into the extraforaminal space. So transpars is very good for extraforaminal, but a lot of people do transforaminal and then pull the endoscope out, and that way you're able to get to any type of extraforaminal or foraminal disc as well. And really that is good for L1 to L5 foraminal, extraforaminal disc, L5-S1 when the iliac crest is low. And then also there are situations that you have a disc that's part of it's paracentral, part of it's perforaminal, part of it's extraforaminal. I had a situation where I had one actually that was central, paracentral, foraminal, extraforaminal. And again, when you're not doing endoscopy, you don't think about discs this way. At least I didn't. But once you do endoscopy, you have to be confident. You know exactly where the disc is. You know exactly where the compression is, because the approach to that disc is completely different on where it is. So this is an example of an interlaminar contralateral approach. So this is an example from one of my professors who taught me endoscopy in 2018 in South Korea. His name is Hyun-Sung Kim. So he really was one of the people that pioneered this approach. So this is someone who had an interlaminar and contralateral approach. So you dock on one side, you kind of roll across to the other side. And for this patient, they had a foraminal and extraforaminal disc. We planned pre-op. This is what we needed to get rid of. And then post-op got a scan showing that is what we got rid of. And then this is an intraoperative photo showing the L5 nerve root decompressed from the medial side of the pedicle, underneath the pedicle, all the way out into the extraforaminal space. So that's a beautiful decompression of the L5 nerve root. So it's a very powerful tool for patients who have a very high iliac crest at L5-S1. But most of the time for extraforaminal or foraminal disc, you are probably doing the transforaminal approach. So in the past, when you're doing tubular far lateral discectomies, if you think about it, the box here is really as far medial as you could go before you start maybe taking too much facet joint that maybe you're destabilizing the patient. We know that you could take half of the joint. So if you can visualize taking half of the joint at this situation, and the bar here shows the window between the iliac crest and your facet joint. So as long as that window is large and your lesion is where that box is, you could do a tubular decompression, no problem. But the endoscope allows you to expand that box. So like I was saying earlier, if you had someone who had a disc herniation all the way over to the other side, and then it came all the way extraforaminally on the ipsilateral side, you really could get all that disc out. It takes a while. I'm not gonna, definitely it takes a long time because you have to slowly just decompress everything. But you're able to do all of that through a 6-7 millimeter incision, which is incredible. And this over here, the lines that we have here show you the differences between the transforaminal or the trans-SAP approach, which is a transforaminal approach where you dock on the superior articulating process. It's really the same thing. Or a transpars approach, which is one that's similar to what we do with a tubular decompression. So you see the box gets expanded with endoscopic. So this is a case here that kind of signifies that. It's a patient of mine when I was going through the learning curve. So this was back when I was still, learning endoscopy. And this patient came in with significant left-sided upper lumbar radiculopathy. And as you can see here, has scoliosis, has foraminal and lateral recess stenosis at L1-2 and L2-3. And he's an older gentleman. He has osteoporosis. The ideal operation for this patient, the robust operation for this patient would have been a multi-level XLIF. But because he is older, didn't have much back pain, and wasn't the best candidate for a large surgery, we said, let's just decompress the foramen and see what happens. And there was there was part of this that was caused by disc, especially L1-2, and part of it that was caused by bony and ligamentous stenosis. So this is a post-op scan. So what happened intraoperatively is that L1-2, I was able to decompress it very well, but it really took a long time. And I was, I did not like, keeping someone who's older like this under anesthesia for a long time. You could do these awake, but I do these under anesthesia. So I asked the team to bring out the tubes. So I ended up doing L1-2 endoscopic and then L2-3 with a tube. And this is a great post-op CT showing how little bone is removed at L1-2 to do this endoscopically. And then how, again, not much bone, but still half the joint is gone, maybe a little bit more to decompress L2-3. So this is a beautiful example of how much less bone is removed with an endoscope rather than with a tube. A patient did very well postoperatively and is doing phenomenal many years later. But this was just a great example of how much less bone you have to remove to do the same job with an endoscope than you do with a tube. This is a post-op scan showing much more decompressed lateral recesses, both at L1-2 and L2-3, much more decompressed foramina at both those levels. So this was really a great learning point for me to demonstrate the utility of endoscopy and also being cognizant of where you are in the learning curve. I think, if I was doing this case now, I would have just definitely could have knocked out both levels with the endoscope, but you have to be always cognizant of that when you're going through the learning curve, and always remember patients first. So patients over ego for sure. So as we are close to the end here, so I was asked to take between 20 to 40 minutes. I wanted to stop at 30, and I think we're at the 30-minute mark. So what are the take-home points from this presentation? So what disc herniations can we treat endoscopically? And it's really any lumbar disc herniation can be treated with the endoscope. In terms of central paracentral disc herniations, you use the interlaminar approach when it's at L5-S1, regardless if there's ligamentous hypertrophy or not. And then at L1 to L5, when there is ligamentous hypertrophy also present as well. And then you do the transforaminal approach when there's no ligamentous hypertrophy, even though, like we talked about earlier, that is a gray area because you could really do a transforaminal approach to decompress both dorsal and ventral. And then for foraminal, extraforaminal lumbar disc herniations, when the iliac crest is high at L5-S1, the interlaminar contralateral approach is a very good approach. Otherwise, really transforaminal or transpars is a workhorse for those types of lesions. So I really appreciate you all inviting me. I appreciate everything that everybody watching this. It's an honor being here, and I'm available for any questions.
Thank you, Dr. Kashlan. Dr. Kashlan, you can stop sharing. Thank you, Dr. Kashlan, for this brilliant presentation. A lot of great videos and absolutely stunning work that you do in New York.
Oh, thank you so much. I much appreciated.
Dr. Kashlan, just a few questions. Now, Dr. Kashlan, endoscopic surgery is gradually picking up all over the world, right? People are gradually shifting to endoscopy. The advantages for the patient, a lot of benefits, like the incisions are small, recovery time is faster. But whenever there's a new technology that's up, people have concerns, like, for example, the complication rates. Now, how have been the complication rates? Like, for example, there are reports like there are higher incidence of seizures, neurological dysfunction, and those are, I think, unique. And there are something that's common between traditional spine surgery and endoscopic spine surgery. For example, uh, epidural hematomas, incomplete decompressions. So, what is the data? All the data that's come up are from top centers, right? From the best centers where they are masters. For example, you mentioned the Korean surgeon from where you learned. So these are masters, and all the level 1 studies have come from some of these centers. So do you think that can be extrapolated to the other centers as well?
So I mean, I think that's you bring up great points. The answer is yes. I think when you have someone, a surgeon who I would say like most of us, people that go into medicine are usually like ethical, good people. I think if you have good insight into okay, I'm this far in the learning curve, there's ways of going through the learning curve without adding any injury to your patients. So whether that's the things that I've seen are I'm going to try endoscopy for 30 minutes and then I'm switching to what I do before. That way you'll get further along every time and you're not under any pressure to finish the whole case with the endoscope. Or, just taking and being very meticulous about choosing what's called an easy case, like things that are more straightforward to start as you're going through the learning curve. I think those are two things that are very personal. Second thing is, it's very good to have mentorship. So I think a lot of these companies, and as the more that people are doing this, you're having people bringing people. So like I have someone who's ahead of me who I ask questions to. I have someone who's maybe 2 or 3 steps ahead of me who I ask questions, and then I have a few people behind me, and then we're all kind of going in that process together. And it's very good to have that there because then you have a community. And when you have one of these weird complications like seizures or high intracranial pressure, all these kinds of things that you get from endoscopy, then you have people to kind of run things by, and it's always good to make sure that that you're not alone. So that's the second thing, having a community. The third thing is honestly the technology is improving. So just like how navigation for putting in pedicle screws allowed all of us to be like Larry Lenke and put screws into a tiny pedicle, you know what I'm saying? So technology really equalizes the playing field. It raises all of us up to the levels of the masters in Korea and the masters, who do this all the time. So I think specific things are navigation for endoscopy. Navigation really helps a lot, in my opinion, in the learning curve because you know where you are at all times. You're not lost. And there are multiple changes to cautery, to drills. All that's still happening right now. So I think that's a huge deal to make this safer, because I do think at some point in the future, this should be able to be done by, any center, honestly.
And Dr. Kashlan, as an extension of the question, see, you said the best retractor is water, right? Water is the best retractor. But sometimes I've seen surgeons using a lot of water. And do you think they are at risk for electrolyte disturbances?
So that's a great question. So the nice thing now is that a lot of the different systems are going to using a pump rather than like a pressure gradient pump. And there's a lot of data. It's going to be coming out soon out of Zurich. Dr. Farshad, I think Mazda Farshad is going to be presented it, but I think it's going to be published soon about what pressure gradients are okay and safe for different areas of endoscopy, cervical, thoracic, lumbar, and also, one of the big things that I was very happy to see, is when you have a durotomy versus no dural tear. No dural tear, you're able to really the study that he will be publishing shows that you could go higher than what you think. So I think with us having a better understanding and having these companies having safer spine-specific pumps, right? Not arthroscopic pumps that they're using for spine. I think those challenges will be a lot smaller, honestly, but it is a problem. Anytime you're above conus, I start so low. I start pretty much where the water is just dribbling, and then I slowly go up. But when you're below conus, honestly, unless you have a dural tear, you could really go as high up as you can. People theoretically used to say historically to the diastolic pressure of the patient, But I think with the studies that are coming out, it might be that we can go even higher. But I think for me, I try never get to even close to diastolic pressure. And when you're anywhere where there's cord, I start where it's like the water has to be dribbling, like, and so that's very important to keep in mind.
Thank you, Dr. Kashlan. Dr. Kashlan, we also joined by Loy. Loy is an orthopedic sports spine surgeon as well, based in Dubai. Loy, welcome to the show. Any questions to Dr. Kashlan, please? Loy, I think you need to unmute.
Unmute me because you
Yeah,
always unmute
yeah.
me. Thanks. Thanks again, Osama, for the great talk. Thanks a lot. Interesting talk. Technical videos and so on. Habibi Osama. One thing, I'm not a spine surgeon, I'm a sports surgeon. I can do everything with sports. I'm not a spine. Learned spine in Germany. I did my residency there. We used to do simple spine cases, but endoscopy is really interesting. Spine is trending nowadays here in Dubai, where I'm practicing. For you, Osama, in your experience, where's the real, because you mentioned a lot learning curve. Where's the real learning curve? Is it the approach? Is it the visualization or handling instruments? For me, as a sports guy, for me, it's handling and the instrumentation as well, or the eye-hand coordination. What do you think is the real curve?
So that's really interesting that you mentioned that. So whenever I'm in any training courses, you always see the orthopedic surgeons pick it up right away, in terms of the handling and stuff, because you guys do way more scopes than neurosurgeons do. So I think for that's very interesting that you mentioned, because definitely you notice it. Like I could tell someone's an orthopedic surgeon versus neurosurgeon.
So we have an advantage for orthopedic surgeon.
Yeah, exactly. Even though I'm a neurosurgeon, I have to say that, like, when you first start, definitely the orthopedic surgeons, they got the scope down. They understand it, they understand the angles way more than neurosurgeons in my experience. But the challenges of endoscopy are honestly attaining hemostasis, so keeping a clean field so you can see what you're doing. It's very challenging with this current level of technology. I have no doubt it's going to get better. And then the second thing is when you're done. Those are the two things that keep you up at night. Like, because if you go to a cadaver lab, anybody can do endoscopy. Anybody, because there's no bleeding. And like, it doesn't matter when you're done, because like the patient won't tell you if they're hurting or not after surgery. But I think those are the two things that I think are very difficult about endoscopy. Keeping a clear field, because if you could do that, anybody can do endoscopy, especially if you have good scope handling skills. And then the last thing, which comes with experience, is when to stop. And there's actually still debates about that now, meaning if you're doing an awake patient, do you pull enough disc until they feel better? Or do you go until it looks perfect? And that's a debate that's happening between expert endoscopic surgeons even now.
Yeah, thanks. The other question is, how would you optimize your working channel trajectory to minimize the nerve root injury, especially when you do the foraminal approach? Is there any way or landmarks that you used to use just to avoid any injury to the nerve roots?
Yeah, so there are many ways of doing that. The ways that I think are the best is, instead of going directly into the foramen with a spinal needle, you could use a Jamshidi needle or use a spinal needle, but you could dock on the SAP rather than into the foramen. And my goal is to do a trans SAP approach, and I use a Jamshidi needle. So I dock on the SAP and then I mallet it, until you're into the foramen. So if you do trans SAP, you're far away from the nerve. So even if you have a big foramen, I always try to go in with the trans SAP approach. So that helps with minimizing the nerve injury. The second thing is when you're doing the approach, and again, I didn't really go into the specifics of the approach because that would obviously be like a whole 20 minutes or so. So it was out of my time, but never to go past on the AP, have a perfect AP, and never go past the medial pedicle on the AP in any reaming or drilling or anything until you're under visualization. So in the lower lumbar spine, medial pedicle, upper lumbar or thoracic, actually it's mid pedicle. So if you're ever worried, just go to mid pedicle, and then you can always, once you get the scope in, you can visualize and everything. But I think doing the trans SAP approach and doing more of a foraminoplasty allows you to minimize the chances of injury of the nerve. Also, for these cases, even though I don't think it will be standard for much longer, because there's studies that show if you do a trans-SAP approach, you don't need it, but using intraoperative neuromonitoring is good to make sure that you're not injuring the exiting root. But people that have done this a lot now will say if you do trans-SAP, like for me, if the neuromonitor people don't show up, I used to wait for them, but if they don't show up, I just keep going because I haven't sensed it to be important for any case in the lumbar spine. If you're upper lumbar where there's conus or above, you have to do monitoring.
Yeah, I mean, worth to mention here in Dubai, neuromonitoring is standard. When I used to work in Germany, we never used the neuromonitoring. I think I feel safer when I use neuromonitoring actually, and it's medical legal here to be documented. Awesome, Osama. Thanks a lot. Thanks a lot for your time, and looking
Yeah,
forward
Dr.
to
Kashlan, we
talk
have
to you
one
again.
question. Yeah, one question from the audience. Just one last question before we wind up. Can you explain what a biportal? Very commonly, we see UBE, unilateral biportal endoscopy, and the other one is the Descendor technique after Jean Descendor. Would you mind explaining these two words because it keeps coming to most of the orthopedic surgeons?
Absolutely. So in terms of biportal, it's a very, honestly, it's a great approach. It's a great approach. I think it has benefits. I don't do biportal, but actually I had a great experience recently. So when was it? I guess 2 months ago. So the Cornell, so Roger Harwell, who's the chief of spine at Cornell, he has a collaboration with a hospital in Dar es Salaam in Tanzania. So every year he has a spine course, and there's a lot of collaboration between the two institutions. And this year, one of his goals was to introduce spine endoscopy there. So I was the person there that was, kind of teaching uniportal. And then there was Don Park, who's a surgeon, orthopedic surgeon at UC Irvine in California, who was there for biportal. And we were doing surgeries. We did 11 surgeries. He had 6, I had 5. And we did them very close to one another. So I was able to observe him and he was able to observe me. So I think it's a very powerful tool. I mean, I think there are some benefits of that over uniportal. I think for me, because I already made it through my learning curve, I'm not sure there's much that I would do biportal. But the benefits of biportal is that you're able to use regular instruments. Like you're able to, so the capital cost for the surgeon and for the hospital is a lot less because you could use what you use for arthroscopic cases. You could use actually what you're using for tubular cases. It's your regular instruments. You're used to it. So I think that's one huge benefit of that approach. And the second thing is, when your hands are like detached, it feels more natural as a surgeon. But when you're doing uniportal, your eyes and the hand are stuck. You're stuck together. So I think for someone who is maybe early on, I have a feeling that where the field will settle, and that's just my opinion, is that maybe biportal will be there for interlaminar approaches, and then uniportal will be for transforaminal. That's what I think. But I think for people that already made it past the learning curve, there's not much that biportal adds, honestly. Maybe for lumbar fusions and stuff, that absolutely. But I think, just going back to what I was saying, just if you could do something with one port, why add a second one? And I think for most cases, you're able to do that. In terms of the Destinal, I actually don't have much experience with that. I saw a video of it. It seems very interesting. It's a bigger endoscope or bigger channel where you could put 2 instruments through it. So I am not sure I'm the best to answer that question, honestly. But because I've never seen it, I've seen videos of it, and it seems like a very promising procedure, obviously, but I can't speak more about it.
Okay. Thank you, Dr. Kashlan. I think that's all the questions that we have for this session.
One last
Yeah,
question.
law. Okay, law is interesting.
Sorry to rush down. It's just an interesting topic for me. Osama, do you have any experience, or would like to to hear your thoughts on plasma laser discectomy? Do you have any experience with this?
I don't have experience with the laser, but I've heard many talks by some of the surgeons in the West Coast here in the US that use it. And they think it's more precise in terms of doing a lot of the work that they do. So I don't have more experience with that, unfortunately, but very interested in learning more, just like you are.
Awesome. So I'm inviting you to visit our department at Dr. Sulaiman Al Habib Hospital here in Dubai. You are welcome anytime to visit us, Osama.
It would be
Thank you, Dr. Kashlan. Yeah, that's all the questions that we have for this session, and really looking forward for more from your side in future. Thank you so much
I
for
appreciate that. I thank you for the opportunity. It's really, really nice to meet you all and hope we meet in person at some point.
Sure. Bye-bye.
All right, take care.